And this is an example of physiological hyalinization. In this case, when you make the diagnosis corpora albicans in an ovary, and if you mention that this connective tissue that composes these corpora albicans is hyalinized, you'll be asked about the types of hyalin. There are 3 different types of hyalin: simple, complex, and lipohyalin. In this case, with physiological hyalinization, the type of hyalin is simplex. Lipohyalin is associated with diabetes mellitus, and complex hyalin usually deposits in immune-mediated diseases and also some other chronic inflammatory processes. You know that in between the ruptured follicle during ovulation and corpus albicans, there is a middle stage of corpus luteum. But unfortunately, here on the slide, we can't find corpus luteum to show you how it looks like histologically. Maybe here there is something, but this is an end stage, not the classic manifestation of corpus luteum. Questions? Slide number 17 is the next one. Gaucher disease. The specimen could be recognized based on these round structures. These are lymph follicles. And in some of them, we can find centrally placed arteriole. In these lymph follicles, we can find there are quite well visible areas with germinal center. The paler thing is in the center is the germinal center, and centrally placed arteriole. Again, I will repeat that the centrally placed arterioles, here again, lymph follicle with germinal center and centrally placed arteriole. So these centrally placed arterioles show us that the specimen is from the spleen, but not from the lymph node. And the other characteristic finding in the spleen trabeculae, these eosinophilic structures. When we zoom in, we can find their components: smooth muscle cells and fibroblasts. Again, characteristic only for the spleen, but not found in the lymph node. And after we say that the specimen is from the spleen, then we focus on the pathologic process, which is seen elsewhere here on the slide. Doesn't matter where you zoom in, you find cells, actually macrophages, with foamy cytoplasm. You can see these small droplets in the cytoplasm. If you make the diagnosis Gaucher disease, you'll be asked, so these macrophages are abnormal findings. There shouldn't be such foamy or so many foamy macrophages within the red pulp of the spleen. So they deposit because of the lack of an enzyme. You know that Gaucher disease belongs to the group of storage diseases, and the missing enzyme is glucocerebroside. No, the enzyme is glucocerebrosidase, and the deposited substrate is glucocerebroside. it can't be degraded because of the absent enzyme. This is a genetic disorder due to a mutation in the enzyme or in the gene coding the enzyme. It is missing. So finally, the glucocerebroside deposits in the macrophages, forming these vacuoles. These are actually the lysosomes, which is the pathologic finding in the spleen. These cells usually deposit not only in the spleen, but also in other internal organs, such as the liver. In the lymph nodes, they could be found as well. And of course, these additional deposits to these organs lead to enlargement of the organs. So hepatosplenomegaly is a classical clinical manifestation of the disease. Questions? Of course, if you get the slide, you can be asked also about other examples of storage diseases. So please learn the classification and a few examples from each group. Now I'm sharing slide number 18, hyalinization of the arterioles and glomeruli in the kidney. How to recognize the kidney? When we zoom in, of course, it should be at the area of the cortex. We can find glomeruli. Some of them are still normal, even show some features of hypertrophy because they are trying to compensate the lost function of the hyalinized ones. In between the glomeruli, there are tubules. These are the tubular structures. And also here in the middle portion of the lower side of the slide, we have one lumen. It is from the hilum. And when we have a closer look at it, we can find that it has an epithelial lining. This is urothelium or transitional cell epithelium. So we can say that this lumen is from a calyx. You know that the calyxes, pelvis, ureters, urinary bladder, and the upper 2/3 of the urethra, all of them are lined by transitional cell epithelium. There is fat tissue from the hilum, of course, large blood vessels again from the hilum. So based on these normal findings of the calyx, glomeruli in the cortex together with tubules, these structures are quite enough to say that the specimen is from the kidney. The other fat tissue that is visible on the other side is from the fat capsule of the kidney. And now the pathologic process. I think that at low, medium magnification, but not the low one, in between the normal glomeruli, or a little bit hypertrophic ones, we can find some others that look like small pinkish balls. Note that they are smaller than the normal ones and they are completely hyalinized. Here again. Also, we can find hyalinization of the arterioles. For example, here this is one arteriole, which wall is thicker because of the accumulation of the same um, homogeneous pinkish material. Here again, next to the glomerulus, we can find an arteriole with severe hyalinization in the wall. Another arteriole with hyalinization. Here again. Here too, next to a hyalinized glomerulus. So finally, based on these findings, we can make the diagnosis hyalinization of the arterioles and glomeruli in a kidney. The hyaline in the blood is in the blood vessel wall, but not in the lumen. The lumen is narrowed because of this thickening of the wall, but still there is some lumen with erythrocytes. So the hyalinization is a process of deposition of hyaline in the extracellular matrix. It's not in the lumen. Perhaps because of the cut section, in some cases, the lumen is really compressed. That's why we can't see it. But otherwise, usually hyalinization of the arterioles does not lead to complete obstruction of the lumen. Don't even comment it. Nobody will ask about it. And if you mean these structures, in some structures we can find homogeneous pinkish material in the lumen, but these are tubules. They are not blood vessels. And this is some proteinaceous material in the tubules, but don't comment them again. Just don't show that these are the hyalinized blood vessels, because they are not. You should see a lumen with hyalinized wall, like here. We have a lumen with erythrocytes and homogeneous pinkish material in the wall. Here again, here again. There is lumen.
But it is lagging.
After you make the diagnosis, you get the question for causes that may lead to disappearance of the kidneys. I think you should start with benign hypertension, and then, of course, diabetes mellitus can cause hyalinization, and you'll be asked about the difference in the involvement of the kidneys by these two diseases. Actually, the difference is in the involvement of the arterioles that are next to the glomeruli. In benign hypertension, only the afferent arteriole is hyalinized, like in our case. I'm searching for an area where, yeah, here. You can see that there is one glomerulus with arterioles. Here is the one and another one here, but only one of them is hyalinized. This is due to the fact that here the cause is benign hypertension. If the cause was diabetes mellitus, then both arterioles are affected by hyalinization, or would be affected by hyalinization. But in both diseases, the process is bilateral because these are generalized diseases affecting both kidneys. Questions? And yeah, if the cause is benign hypertension, again the type of hyaline is simple. While in diabetes mellitus, as I mentioned, the type of hyaline is lipohyaline.
We're on slide 19 now.
I just shared the slide number 19, amyloidosis of the kidney. Here again, we can find the cortex, which is the right side of the slide. The medulla is here, and the lumen that is directly under the medulla is the calyx. Unfortunately, here the epithelium is not that well preserved. We have only some remnants of epithelial lining. But just theoretically, if you're asked, don't forget that the type of epithelium here is urothelium or transitional cell epithelium. Then in the medulla, we can find only collecting ducts. In the interstitium, we can find some areas that look more homogeneously pinkish. So this could be also amyloid deposits. Here again. But of course, we should check it with a special staining. The special staining for amyloid is Congo red staining, leading to orange staining um, of the amyloid, and it's apple green if we use the polarized microscope. For the cortex, it's a little bit more difficult to find the glomeruli, although if you use the medium to higher magnification, you can find some round structures which are exactly the glomeruli. Although we can't see the Bauman space, these are still the glomeruli. We can find their roundish outlines. The Bauman space looks obliterated because of the fact that the glomerular tuft is enlarged due to the deposition of the homogeneous pinkish material in the interstitium between the capillaries. Exactly, this is the amyloid. Note that the size of the glomeruli here is enlarged compared to the previous slide in hyalinosis, where the size of the glomeruli is decreased compared to the normal ones. Here, the glomeruli are enlarged. Of course, if we use the Congo red staining, these deposits will be covered in dark orange again. If we use the light microscope with polarized light, as I mentioned, it will be apple green. Here again, we have some glomeruli. Just a second.
I'm screen recording, Hermiela. Yeah. Yes. Yeah, but I screen recorded for like 15 minutes and I checked it and I saw there was no sound and then I figured out how to put in sound.
I didn't hear. What?
Yeah, I screen recorded the first 15 minutes and then I checked it to see if I got with sound and I didn't. And then I figured out how to bring sound in. So I had to screen record again. So the first 15 minutes is lost.
Mm. But you took notes.
Yeah. But now now it's clear. She's on the
How are you screen recording?
this side.
Yeah,
Sorry.
I'll show you later.
Oh, it's a QuickTime recorder. Okay, then I don't need it. I'm just struggling to record my phone. You see my phone is like just sitting like this in the computer.
Yeah, but the preserved glomeruli, which are not affected by hyalinization, are a little bit hypertrophic to compensate the lost function. But the hyalinized glomeruli themselves are decreased in size.
I asked 2 people. They said,
while the glomeruli that are affected by amyloidosis, they are enlarged.
Log in by your phone.
So here we compare the affected glomeruli. I'll mention something that is really prominent on the slide, but please don't discuss it if you are not asked during the exam. There are some tubular structures which are highly dilated. All of these things are tubules, and they are dilated and filled with homogeneous pinkish material, but this is not the amyloid. This is proteinaceous material from the urine, because usually patients who are affected by amyloidosis, kidney amyloidosis, I mean, this is associated also with proteinuria, because the capillaries become more leaky and some proteins from the plasma leave the capillaries into the urine, and we can detect the proteinaceous material in the tubules. But this is not the amyloid. The amyloid is in the interstitium between the capillaries, and it could be also in the interstitium between the tubules. If you are asked about the pinkish material within the tubules, say that this is due to the proteinuria. But these are not the beta-pleated proteins that are insoluble, characteristic for the amyloidosis. If you are not asked, just don't mention the tubular changes, because the main pathologic process here on the slide is the amyloidosis of the glomeruli, affecting the glomeruli. Questions? And yeah, there is another prominent thing that you shouldn't mention from the very beginning, but only if you're asked. There is one blood vessel here, very large.
Where?
One, which contains a thrombus. So, or it could be an embolus, of course. It depends on if it's attached to the wall or not. But the thing is that it is composed of meshwork of fibrin strands intermixed with red and white blood cells. So, as we saw in the morning, this is the quite characteristic morphology of a thrombus. Or, again, I'll repeat, it could be a thromboembolus again. But because the fact that here this thrombus or embolus has nothing to do with the amyloidosis, and it's not caused by the amyloidosis, but it's just an additional finding. That's why I'm telling you not to mention it from the very beginning, but only if you're asked. Because if you mention it, then the discussion may take the road to thrombi formation, Virchow's triad, where could it be formed, where could it come from, and so on and so on. So your situation will become more complicated than it is, I think. Of course, if you're asked, you should answer what you see here in the blood vessel. Otherwise, for the slide, if you make the correct diagnosis amyloidosis, then theoretically, you can be asked about the types of amyloidosis, the special staining, of course, and so on. Questions? Now I will skip slide number 21, that is bronchial metaplasia with carcinoma in situ, because I prefer to discuss it together with the tumors to show you the difference between in situ cancer and infiltrative cancer. That's why we will discuss it next week. Just please remind me that we should also discuss slide number 21. Now we will continue with inflammatory processes, one of which is seen on slide number 22, phlegmonous appendicitis. On this slide, we have an organ with its whole circumference and different layers. The pinkish layer is the muscular layer of the wall, but of course we'll start from the lumen. Here actually the lumen is not that well visible. There are only some remnants of lumen because it is completely filled with inflammatory cells as well. But still we can find some remnants of mucosal lining, these crypts. Here again, these are the colonic crypts. You know that the colon is lined by goblet cells, but here we can't find the large mucin vacuole within the cytoplasm of the cells. This is because of regeneration. When there is a process leading to damage of the mucosal lining and necrosis or atrophy, the preserved part of the mucosa starts to proliferate, trying to cover the defect, the damaged part of the mucosa. And so when there is regeneration, usually the mucin vacuoles are absent and the cells show some features of even of atypia, but this is regenerative atypia, not the true atypia seen in malignant tumors. Even here in some areas we can find inflammatory cells in between the epithelial ones. These are neutrophils, which is another evidence of severe acute infection. So this is the mucosal lining, actually only remnants of it. The next layer is submucosa, after it lamina muscularis propria, subserosa, and serosa is the outermost layer. Here on the slide, it's quite well visible that we have some dark areas throughout the whole layers of the wall. And these dark elements are exactly the inflammatory cells. When we start from the lumen, we can find many neutrophils. Then we move to the outer layers. This is the submucosa. Before we see these bundles of smooth muscle cells, this must be the submucosa, where we can find the same cells, inflammatory cells, neutrophils, which then move also in between the smooth muscle cells. And finally, they are also found in the subserosa here. And oops, what happened? Okay. And even the serosa is affected. Maybe here it's better seen that there are inflammatory cells over the serosal lining. This means that this acute inflammation, of course, it's acute when we have such diffuse infiltration by neutrophils. You know that acute inflammation is associated with polymorphonuclear cell infiltration, while chronic inflammation is associated with mononuclear cell inflammatory infiltrate, or lymphocytes and plasma cells are the mononuclear cells. So here, this diffuse infiltration by neutrophils shows us that the inflammation is acute, and it's also diffuse because it involves all of the layers of the wall. So finally, we can call it phlegmonous appendicitis. If you remember, the phlegmon is the word used for diffuse purulent inflammation. How do we call the localized purulent inflammation? It's an abscess, that's right. Okay. About common complications is one of the questions that is asked very often during the exam. So the most common complication is peritonitis, because the inflammation, after it involves the full thickness of the wall, then it spreads to the peritoneum as well. Fortunately, it is localized in most of the cases. It may also lead to periappendicular abscess. Yeah, in some cases it may spread also to adjacent organs. For women, for example, the inflammation may spread to the ovaries and the fallopian tubes. So it may lead to salpingitis, is the name of the inflammation of the fallopian tube, and ophoritis is the inflammation of the ovaries. Of course, it could be salpingo or ophoritis, so mixture of inflammation of both structures. Questions? Yeah, the cause of such a diffuse bacterial inflammation usually is obstruction of the lumen of the appendix. When there is no normal drainage of the appendix to the cecum, because it's obstructed by a really hard feces. This is known as fecalith. I'll write it down. typically it looks like a stone made of feces, and when it obstructs the lumen of the appendix, this leads to infection within the appendix, and finally may progress to phlegmonas appendicitis. Questions? The next slide is number 23, fibrinous pericarditis. In the morning, we already discussed the localized fibrinous pericarditis, which was over an area of a myocardial infarction. But here in the myocardium, when we zoom in, we will see that there is no necrosis. The cardiomyocytes contain their nuclei. In some areas, we can't find the nuclei, or within some of the cells, we can't find them because of the fact that this is more transversal or a little bit oblique. 23. Fibrinous pericarditis is the name of the slide. So because of the cut section that is transversal or a little bit oblique, that's why in some cases the cut section could be not through the nucleus. That's why we can't see it. But otherwise you can compare the cytoplasm of cells that contain their nuclei, and it looks exactly the same way. The lipofuscin is again well visible, the yellowish granular pigment surrounding the nuclei. So really doesn't matter where you zoom in. There is no necrosis in this slide of the myocardium. Then the myocardium is covered by epicardium. This is the next layer. Epicardium usually is composed mainly of fat tissue that is separated by small amount of connective tissue. And finally, the outermost layer of the heart is pericardium. But here the pericardium is diffusely inflamed because of deposition of fibrin strands, this meshwork of pinkish strands, intermixed with inflammatory cells. Some of the inflammatory cells are neutrophils. Unfortunately, honestly, on this slide, we can find mainly mononuclear cells. You know that fibrinous inflammation is an example for acute inflammation. It's a type of acute inflammation. So usually in between the fibrin strands, we expect to see neutrophils. But here, I would confirm that most of the cells are mononuclear but not neutrophils. Here and there we can find some neutrophils, but they are not that many as they should be. But still, if you get the slide during the exam, at least you can show that you know how the different types of inflammatory cells look like, and say that as a type of acute inflammation, here you expect to see more neutrophils than mononuclear cells, but here perhaps the inflammation is long lasting, and that's why we already have enough mononuclear cells as well. Another feature of acute inflammation that is quite prominent is the hyperemia. Hyperemia is the dilation of the capillaries, and they are filled with erythrocytes. Of course, if we want to confirm the type of inflammation, we can use the PTAH and Weigert staining for fibrin, and it will be colored in blue. Also, as a cause for the inflammation here, actually you can't mention the myocardial infarction because obviously there is no myocardial infarction. That's why the thing that you should discuss is uremia. Uremia is actually increased levels of urea in the blood, which occurs in patients with chronic renal failure. Not only urea, but creatinine and also other wastes increase their levels in the blood in these cases. And usually these wastes are eliminated through the serosal surfaces, leading to diffuse fibrinous inflammation, not only of the pericardium, but also the pleura and peritoneum. So here, I would say that this is more as an example of diffuse pericarditis, fibrinous pericarditis, than a localized form, like it is when it's over an area of myocardial infarction. If you already had to look at the videos with the jars with gross specimen, this is one of the jars, examination jars with gross specimen, the fibrinous pericarditis. In this case, we call the gross appearance of the heart cor villosum. Cor villosum. If you get the more histological slides, you may be asked about the gross appearance of the heart as well. Questions? I shared with you slide number 24, pulmonary abscess. Unfortunately, here on this slide, the abscesses are quite prominent. Actually, there is not only one abscess, but several of them. All of these cavities, they are abscesses, even this large one. Unfortunately, it's not that easy to recognize the organ. You need to use medium magnification. And at this medium magnification, it's easier, I think, here at the upper side to see two lumina with dark peripheral areas. These are bronchioles, because when we zoom in, we can see that these lumina, which are also filled with erythrocytes and inflammatory cells, but at the same time they are lined by pseudostratified columnar ciliated epithelium. There is another one here. These bronchioles are severely inflamed too. There is no cartilage and glands in the wall, that's why we decide these are bronchioles, but not bronchi. Unfortunately, the alveolar spaces, maybe here in the middle portion, we can find a zone with partly empty alveolar spaces, although in all of them we can find some cells, erythrocytes, siderophages, inflammatory cells. So the lung parenchyma is severely inflamed. The inflammation of the lung parenchyma, which histologically is visible with inflammatory cells within the alveolar spaces, within the alveoli, is known as pneumonia. So here in this slide, we have pneumonia because of the inflammatory cells in the alveolar spaces. Here we can find some neutrophils. But also, this pneumonia is associated with formation of abscesses. We already mentioned that the abscess is a localized purulent inflammation, and histologically this localized purulent inflammation is visible as a cavity filled with neutrophils or polymorphonuclear cells. So finally, we can make the diagnosis pneumonia with formation of abscesses or absceding pneumonia. This is a type of bronchopneumonia. No, don't classify the pneumonia this way in this case, if it's typical or atypical. Just say that this is a bronchopneumonia with formation of abscesses. Because you can be asked about this classification of pneumonias to bronchopneumonia and lobar pneumonia. Lobar pneumonia will be the next one that we are going to discuss in a few minutes. So here bronchopneumonia, because as we saw, we have both inflammation of the bronchioles and the lung parenchyma. Also here, now I saw that this is one bronchiole as well, and partly its epithelium is still preserved, but at the same time its lumen is highly infiltrated by inflammatory cells here as well. So the simultaneous inflammation of the bronchioles with lung parenchyma means that this is bronchopneumonia, and we can find abscesses. Then you definitely get the question for inflammatory agent associated with such a pneumonia. On the first place, you should mention Staphylococcus aureus. Usually, exactly, this is the bacterial agent associated with abscesses. Another question that you may get is about the complications of such pneumonia. Actually, the abscesses is are a type of complication of the pneumonia. Another complication could be pleuritis if the inflammation involves the lung parenchyma that is next to the pleura. Then it may spread to the pleura, leading to purulent pleuritis. Of course, it will be purulent because here the type of inflammation is purulent or suppurative, right? When we have abscesses, you know that the definition of the abscess is localized purulent inflammation. So generally here the inflammation is purulent or suppurative. And if it spreads to another adjacent part, then the inflammation will be the same type. The inflammation could spread also to the pericardium, leading to purulent pericarditis. It may give rise to a sepsis as well. It depends on the size of the abscess. If there are multiple small abscesses like these ones, they can't be drained. But if there is a large abscess, it can be drained, and in many cases, large abscesses drain themselves within the bronchi, and then they are excreted as sputum. Any other questions? I just shared with you the last slide from acute inflammation. It is Krupa's pneumonia, slide number 25. You know that Krupa's pneumonia is also known as lobar pneumonia. Here, even at low magnification, we can see that all of the alveolar spaces are completely filled with exudate. Also, there is an area with a bronchus here, the upper right side, because the purple material is cartilage, and it is next to a lumen lined by pseudostratified columnar ciliated epithelium. Here the cilia are quite well visible. Yeah, partly the epithelium is missing, but still we can find some zones where we can recognize it. There is another lumen with epithelium here. Honestly, here the epithelium is more damaged than in the left lumen. There are coniophages in the interstitium around the bronchi, macrophages with coal dust. And then we concentrate on the appearance of the alveoli. We already mentioned that they are all filled with exudate. When we zoom in, we can see that this exudate is composed of a meshwork of fibrin strands intermixed with inflammatory cells. These inflammatory cells are neutrophils predominantly, and here and there we can find some dispersed erythrocytes. Here again, there are neutrophils in the meshwork of fibrin strands and erythrocytes. Of course, here the special staining could be used again. The two special stainings, PTAH and Weigert staining. And another characteristic feature of Krupa's pneumonia is the artificial whitish spaces that are formed between the alveolar walls and the exudate. They are formed during the routine processing of tissues when the fibrinous inflammation, the fibrinous exudate, shrinks due to the routine processing of the tissue, leading to detachment of the exudate from the alveolar wall. Otherwise, in an alive individual, the exudate fills in everything. There is no free space between the exudate and the alveolar wall. But these artificial clear spaces occur during the routine processing of the tissue, exactly because of the fact that the inflammation is fibrinous. Within the septae, we can find dilated vessels from the microcirculation, which are filled with erythrocytes. This is again hyperemia that is characteristic for all the variants of acute inflammation. You'll be also asked about stages of Krupa's pneumonia. There are 4 stages. The first one is congestion. The second one is red hepatization. Gray hepatization follows the third. This is the third stage. And the fourth stage is resolution. On our slide, we have the stage of gray hepatization, which is characterized with the fact that there are more neutrophils than erythrocytes. In contrast to the previous stage, red hepatization, where the erythrocytes are the predominant cells. Another question that you get is about a common complication of Krupa's pneumonia. It is carnification, which occurs if there is no resolution of the exudate. Carnification. So if the exudate is not resorbed, then there is organization, and this organization of the exudate is known finally as carnification. Organization means that there is growth of connective tissue within the alveoli at the place of the exudate. Usually it happens through the stage of granulation tissue. The cause for Krupa's pneumonia is Streptococcus pneumoniae. In 95% of cases, even more than 95% of cases, this type of pneumonia is caused from pneumococcus or Streptococcus pneumoniae.
Where are you?
Questions? If there are no questions, then the last slide for today will be number 26, granulation tissue. I mentioned it several times today. You know that granulation tissue is formed at areas of healing infarctions when the tissue is not, or the parenchymal cells are not capable of dividing. These cells are replaced by fibrous tissue finally, but in the middle stage of regeneration, there is formation of granulation tissue. This is one of the areas where we can find it, like in myocardial infarction during the healing stage. It is also formed at the base of wounds. This is a theoretical question, as an answer for theoretical question when you're asked about from where the specimen could be taken from. Because here on the slide we have fragmented material composed entirely of granulation tissue, so we do not have any normal tissue here to say exactly from which part of the body it's taken from. So the thing that you should recognize is the granulation tissue itself. It is composed of proliferating capillaries, small blood vessels, which are within an edematous stroma. Edematous stroma means that this is stroma with edema. The whitish thing is the edema. And along with the edema, there are inflammatory cells in this stroma. For granulation tissue, because as I mentioned several times, usually it's formed in the middle stage between acute and chronic inflammation, or in the healing stage of infections or healing stage of wounds. That's why the inflammatory cells that accumulate in the stroma are mixed. We can find both polymorphonuclear cells together with mononuclear cells, lymphocytes and plasma cells. Also, because of hemorrhages, you can see that there are many siderophages, these macrophages with granular brownish pigment are siderophages. I'm trying to find an area with better morphology of the cells. Just to remind you that the plasma cells, for example, this is a plasma cell with eccentrically placed nucleus. We can see the cytoplasm on the other side, and there is clear halo around the nucleus. This clear line surrounding the nucleus is the clear halo. This is in contrast to the lymphocytes, which are just like dots without cytoplasm around them. We already saw polymorphonuclear cells several times, but here there is one as well. We can count 1, 2, 3 dots of the nucleus. This is a polymorphonuclear cell. And another polymorphonuclear cell here. Here again there is a polymorphonuclear cell. Some plasma cells, these 2, even 3. We can see the nucleus and cytoplasm on the other side. Lymphocytes, just like dots. Here as well. And don't forget that there are fibroblasts in the granulation tissue. These fibroblasts are needed to proliferate and to produce collagen, because finally the granulation tissue transforms into fibrous tissue or connective tissue. The fibroblasts are cells with spindle-shaped cells with elongated nuclei. Oh, this is not the best area.
When is the class start?
In 2 minutes.
Oh.
No, 1 hour and 30 minutes. It's 2:30 already. Oh, I'm so cold.
Honestly, in our case, it's not that easy to find some fibroblasts. Oh, here there are some. These cells, spindle-shaped cells with elongated nuclei. These are fibroblasts. Here again. Here again. Here too. These are fibroblasts. So usually in the early formation of fibers of the granulation tissue, there are only a few areas with fibroblasts. But yeah, with the time, these fibroblasts proliferate, forming more and more collagen. Finally, this collagen and the fibroblasts replace the whole granulation tissue.
Yeah, it doesn't feel like.
Perhaps this is just taken from an area with an early formed granulation tissue.
So dirty.
Here we can find some fibroblasts as well.
You're done for the day?
Yeah, we just finished.
I still have
Some
surgery.
hemorrhages are visible. Of course, they are always present when we can find so many siderophages.
Oh,
Questions?
can you? What the hell? What is this? Okay,
If you do not have any other questions, this will be the last slide for today. Don't forget to remind me about the slide number 21 for next week, when we will start from slide number 27. Again on Monday at 9:30. I hope that you can join both classes again to finish all the slides with both groups. Thank you for joining the classes today and see you next week. Thank you. Bye.
How many slides are